I want you to do something for me before we go any further. Think back to the last time you walked into your garage, or maybe it was a storage shed, a basement, a spare room you keep telling yourself you'll sort through when you have the time. You went in, you moved a few things around, maybe noticed a little dust, maybe spotted a few droppings in the corner that you made a mental note about, and then forgot entirely. You were in there maybe 5 minutes, you walked out, life continued. Now I need you to sit with this. That 5 minute trip, completely ordinary, completely forgettable, may have been the moment you encountered one of the most quietly dangerous pathogens circulating in North America right now. No animal bite, no scratch. No physical contact with anything that was visibly wrong, just the simple automatic act of breathing in an enclosed space. That is what separates hantavirus from almost every other virus you have been warned about in recent years. And that is precisely why I am here today. My name is Dr. Ava Wilson, and I want to have an honest conversation with you. Not the kind driven by alarming headlines, not the kind designed to spike your anxiety and send you scrolling for more. The kind grounded in biology, in clinical reality, and in the specific information that actually changes outcomes. By the time we are done here, you will understand exactly what hantavirus is. You will know how it enters the human body and what it does once it is there. You will understand why adults over 60 carry specific risk considerations that most of the coverage this week has completely glossed over. And you will walk away with concrete, practical steps you can apply immediately for yourself and for the people you love. There is one concept I need to introduce you to right now before we go any further into the science. I call it the quiet window problem. It is the single most important thing to understand about this particular virus, and I will walk you through it in full. But I need you to hold on to that phrase as we build toward it together, because it fundamentally reframes how you think about exposure risk and what to do about it. Before we begin, where are you watching from today? Drop your city or your country in the comments. I read every single one, and I genuinely want to know who is in this community. Now, let's talk about what this virus actually is. The first thing I want to do as your physician, not as a headline, is root this conversation in biology. Because the word hantavirus is being thrown around in news coverage right now as though it refers to one specific singular threat. It does not. Hantavirus is a family of viruses. More than 40 known species fall within that family, a number that has expanded considerably as genomic sequencing technology has advanced. These viruses have been circulating in rodent populations and occasionally crossing into humans for decades. The name traces back to the Hantan River in South Korea, where scientists in the 1970s identified one of the original strains while studying illness patterns in soldiers stationed near the Korean border. That was over 50 years ago. Here's the piece of context I need you to have because it is almost entirely absent from this week's coverage. This is not a new virus. This is not a novel pathogen that the scientific community is scrambling to understand. This family has been studied by infectious disease specialists and epidemiologists for half a century. It has never gone away. It has been present continuously in North America, in Europe, in Asia, in South America. What shifts is not the virus itself. What shifts is the degree of human activity that brings people into proximity with the environments where this virus lives. And here is the question I want you to apply to every health headline you encounter going forward, because it is the question I apply as a clinician. Is this pathogen novel or known? Novel pathogens, the ones we have never encountered before, with no established data on transmission, no baseline immunity in the human population, no tested clinical framework. Those are the ones that justify urgent population level concern. Early 2020 with SARS-CoV 2 was the textbook example. Nobody understood how it moved. Nobody had established immunity. Nobody had a treatment framework with any real world validation. That genuine documented uncertainty was the engine of the danger. Hantavirus is not in that category. Its transmission routes are documented. Its clinical presentation is well characterized. The uncertainty that makes novel pathogens so devastating simply is not present here. That is not a reason to dismiss it. It is a reason to engage with it intelligently, which is exactly what we are doing. Before we go further, drop your name in the comments and tell me where you're tuning in from. I go through every single comment and I want to know who I'm speaking with today. Now let's talk about how this virus actually moves from one place to another, because I am seeing real confusion on this point and I want to address it directly and clearly. Many people I have spoken with this week made an immediate assumption that hantavirus spreads the way COVID-19 spread: respiratory transmission, person to person, shared indoor air, a restaurant, a plane, a crowded room. That assumption is medically incorrect, and it matters enormously for how you assess your actual risk. For virtually all known strains circulating in North America and most of the world, hantavirus is not a human to human pathogen. It is a rodent borne virus. It lives in the bodily excretions of specific rodent species: urine, feces, saliva. In North America, the primary carrier is the deer mouse. Across parts of Europe and Asia, different rodent species carry different strains. Now, here is the mechanism. This is where I need your full attention because this is the piece that most people skip past, and it is the piece that explains everything. Those rodent excretions do not have to be fresh to be dangerous. They dry, they desiccate over time. As they break down, they fragment into microscopic particles, particles so small they are invisible, carrying no odor, no color, no sensory signal of any kind. Those particles become suspended in the air of whatever enclosed space the rodents have been inhabiting. When a person walks into that space and breathes, they inhale those particles. That inhalation is the exposure event. Think about the spaces that create this scenario: a cabin sealed up through winter, a shed that hasn't been opened in months, an attic with aging insulation, a barn, a storage unit, a basement, a crawl space, anywhere that small rodents can find shelter, nest, and leave traces of their presence over weeks or months. You walk in, you start shifting boxes. Those particles, settled on surfaces, on cardboard, on the floor, get disturbed. They go airborne again. You breathe. You feel completely fine. You walk back out and go about the rest of your day. That is the exposure event: silent, undetectable. No alarm goes off in your body. There is nothing to feel in the moment. And this is exactly where the quiet window problem begins. I will come back to it. And when I do, I promise it will land differently now that you understand the mechanism. But first, the protocol, because this is immediately actionable and I want you to have it now. If you need to clean any enclosed space showing signs of rodent activity, droppings, nesting material, gnaw marks, anything, here is the sequence. Follow it completely. Follow it in order. Every time. Step 1. Before you touch a single thing, open every window and door in that space. Let it breathe. Wait a minimum of 30 minutes before you enter to work. Step 2, put on an N95 rated respirator, not a cloth mask, not a standard surgical mask, an N95. The particle size we are dealing with requires that filtration rating. Add rubber or plastic gloves before touching any surface. Step 3, mix 1 part household bleach to 10 parts water. This is your disinfectant solution. Step 4, wet contaminated surfaces with that solution before you move or touch anything. You are neutralizing the virus before you risk disturbing particles into the air. Step 5, never dry sweep. Never run a standard vacuum cleaner in that space. Both actions aerosolize particles directly into your breathing zone. If you use a vacuum, it must have HEPA filtration. Step 6, double bag all waste material. Remove and dispose of your gloves and mask after exiting. Wash your hands thoroughly with soap and water. That protocol, applied correctly and completely, dramatically reduces your exposure risk. It is not complicated, but it must be the right steps in the right order without shortcuts. If this is the kind of information no one has given you before, subscribe right now, because there is much more ahead, and what comes next, you genuinely need to hear. Let's talk about what hantavirus actually does inside the human body, because there are two distinct disease presentations, and they operate through entirely different mechanisms. Understanding both of them matters, particularly for this audience. because certain health patterns common in adults over 60 interact with each presentation in very specific ways. The first is hantavirus pulmonary syndrome, or HPS. This is the presentation most relevant if you are in North or South America. In the earliest phase, it is almost indistinguishable from influenza, fatigue, muscle aches, fever, headache, possibly some nausea or dizziness, the kind of symptom picture that most adults reasonably attribute to a seasonal bug and manage at home with rest and fluids. Then, typically between 3 and 7 days after symptoms begin, something shifts. The virus, which has been quietly replicating and moving through the bloodstream, begins attacking the small blood vessels inside the lungs. Fluid accumulates in lung tissue. Oxygen levels begin to fall. Breathing becomes labored. What makes this presentation so clinically dangerous is the speed of deterioration once that shift occurs. We are not talking about a gradual decline over weeks. In severe cases, a patient who was functional yesterday can be in acute respiratory distress within 24 hours. The case fatality rate for hantavirus pulmonary syndrome is approximately 35 to 38%. I am going to pause on that number, not to alarm you, but because I believe in being honest with you the way I am honest with my patients. Roughly 1 in 3 people who develop full pulmonary syndrome does not survive it. That number warrants your serious attention. The second presentation is hemorrhagic fever with renal syndrome, or HFRS, far more prevalent in Europe and Asia. Here, the virus targets the kidneys, not the lungs. It causes significant kidney tissue inflammation, internal bleeding, and in serious cases, acute kidney failure requiring dialysis. The case fatality rate for HFRS ranges from 1 to 15% depending on the specific strain. The Hantan and Dubrava strains sit at the more severe end. Strains like Pumala tend to cause milder disease with fatality rates below 1%. 1 to 15% is still clinically serious, particularly when your kidneys are the organ under direct assault. Now, and this is where I want to speak specifically to you if you are over 60, because this nuance is almost never addressed in general coverage. If you have any existing kidney disease, reduced kidney function, or are managing conditions like hypertension or diabetes, both of which place chronic low-level stress on kidney tissue, your kidneys are beginning from a different baseline than a healthy 30-year-old's. That does not make exposure automatically fatal. What it means is that the margin for deterioration before the situation becomes critical is narrower. You have less physiological reserve to absorb the assault before organ function is significantly compromised. The same logic applies to pulmonary syndrome. If you have any history of COPD, reduced lung capacity, sleep apnea, or cardiovascular disease, conditions that are genuinely common in this age group, the speed at which falling oxygen levels become a crisis is different for you than for someone with full baseline lung function. I am not telling you this to frighten you. I am telling you this because it is medically accurate and because it changes one specific critical thing, the threshold at which you should seek emergency care, which brings me finally to the quiet window problem. If you are still here and finding real value in this, type the number 2 in the comments right now. It tells me you are engaged and it helps me understand what this community needs next. Here is the piece of information that changes everything, and the piece that almost no mainstream coverage is giving you. The incubation period for hantavirus ranges from 1 week to 8 weeks for most known strains. For the Andes virus specifically, the strain confirmed in the current cruise ship outbreak, the documented window is 4 to 42 days, with the majority of cases presenting symptoms somewhere in the 2nd to 4th week after exposure. Read that again, 1 week to 8 weeks. That means the gap between the moment of exposure, that unremarkable 5 minutes in the garage I described at the very beginning of this video, and the appearance of the first symptom could be as long as 2 months. For 56 days, nothing. The person feels completely normal. They sleep well, they eat, they exercise, they spend afternoons with grandchildren, they attend doctor's appointments for entirely unrelated things. The virus is present, it is replicating. Their immune system is responding at a cellular level in ways that will not surface as recognizable symptoms for weeks yet, and they have absolutely no awareness that any of this is happening. Then symptoms emerge, often suddenly, often already looking like something is seriously wrong rather than I might be coming down with something. This is the quiet window problem. The silence between exposure and consequence is so long that the two events have no obvious connection in most people's minds. The woman who cleared out her storage unit in March does not connect that afternoon to the fever and muscle aches that arrive in late April. She assumes influenza. She waits it out at home, and in doing so, she loses critical hours, sometimes critical days, before anyone understands what they are actually dealing with. This is why what I am sharing with you today matters more than any symptom checker or breaking news headline. Because the intervention that changes outcomes with hantavirus is not a medication. There is no approved antiviral specifically for hantavirus. The intervention is early, informed escalation to emergency care and accurate communication with the physician when you arrive. Here is the exact sentence I want you to memorize. If you have any potential rodent exposure in your recent history and you develop symptoms, say this to the emergency room physician. I was in an enclosed space with signs of rodent activity approximately this many weeks ago. I am aware of hantavirus and want to make sure it is being considered in the differential. That one sentence changes the diagnostic process. It puts hantavirus on the clinician's radar early, and early supportive care, oxygen supplementation, fluid management, and respiratory monitoring is what shifts outcomes. The window for that care to be maximally effective is measured in hours, not days. Know the symptom triad: fever, plus significant muscle aches, plus shortness of breath developing progressively within the 1 to 8 week window after any potential rodent exposure. That combination is your signal to move, not to wait and see, not to assume it is seasonal, to move. Now, let me address the global risk picture because this is where I see the most dangerous misinterpretation of health information playing out in real time. The World Health Organization and the CDC have assessed the overall population level risk from hantavirus as low. If you encountered that language in the coverage this week and felt reassured, I understand why. And I also want to explain with precision why that reassurance may not apply to your individual situation. Population level risk statistics are calculated by averaging exposure likelihood and outcome severity across enormous, extraordinarily diverse populations: urban populations, suburban populations, people in high rise apartments with zero rodent exposure, people in countries with established rodent control infrastructure. When you average all of those people together, yes, the population level number looks low. Your individual risk is not determined by population averages. It is determined by your specific circumstances. If you spend time in rural or semi rural environments, a vacation property, a hunting cabin, a family farm, your exposure context is meaningfully different from someone whose entire life takes place in climate controlled urban buildings. If your work involves older structures, soil, outdoor environments, wildlife management, pest control, or agriculture, your occupational exposure is not captured in the general population average. If you are currently in the process of clearing, renovating, or cleaning any structure that has been unoccupied or rodent accessible for an extended period, that specific activity elevates your individual risk in ways that broad population statistics simply do not reflect. Low global risk is accurate information. It is not, on its own, a sufficient basis for your personal health decisions. One additional note: the Andes virus, circulating in parts of South America, has documented cases of person to person transmission, a characteristic virtually no other hantavirus strain shares. It remains limited in transmission efficiency, but it is the reason the cruise ship situation is receiving the monitoring it deserves. For every other major strain, including the strains most likely to be relevant to viewers in North America and Europe, rodent exposure is the mechanism. Person to person transmission is not a documented feature of those strains. I want to spend a few minutes on something that sits underneath every conversation about infectious disease risk in this age group: something I talk about with my patients regularly and that I think deserves a direct, honest conversation here. Your immune system at 65 is not the same system it was at 35. That is not a pessimistic statement. It is a biological reality with very practical implications. The process is called immunosenescence, the gradual, progressive shift in immune function that occurs across decades of life. Your immune system's speed of first response, its precision in identifying novel threats, its capacity to mount a vigorous inflammatory response and then regulate that inflammation back down to baseline. All of those functions become measurably less efficient with age. In practical terms, for a viral threat like hantavirus, this means your immune system may take longer to recognize and respond, and the organs it needs to protect are already starting with reduced physiological reserve. But here is what I also want you to hear clearly. There are things within your control that directly and meaningfully influence immune function at this stage of life. Sleep is the most consistently underestimated lever in this conversation. Consistent, quality sleep of 7 or more hours per night is not a luxury. It is when your immune system conducts a significant portion of its surveillance and repair work. Chronic sleep restriction measurably degrades that function. Full stop. Vitamin D status is disproportionately low in adults over 60, particularly those who spend limited time outdoors. Vitamin D deficiency directly impairs immune response speed and the quality of the immune cascade. A simple 25 hydroxy vitamin D blood test gives you actionable information. Ask your physician about it at your next visit. Chronic inflammation, driven by elevated blood sugar, visceral abdominal fat, and sedentary lifestyle, acts as a constant low grade drain on immune resources. An immune system perpetually managing background inflammation has fewer resources available when an acute pathogen arrives. And for anyone managing existing conditions, kidney disease, hypertension, diabetes, COPD, cardiovascular disease, please have a direct conversation with your physician about your individual risk picture. The interaction between your existing conditions and the specific organ systems hantavirus targets makes your personal medical history genuinely relevant to how you approach this. Let me give you the clean summary because you deserve clarity, not just information. Hantavirus is a known, studied virus family, not a novel, emerging pathogen. It does not spread through ordinary human contact. It spreads through inhaling microscopic particles from the dried excretions of infected rodents in enclosed, unventilated spaces. The exposure is silent, odorless, and entirely undetectable in the moment it happens. The incubation window, 1 to 8 weeks for most strains, 4 to 42 days specifically for the Andes virus, is the quiet window problem. It is what makes awareness and preparedness more valuable than any reactive response after symptoms appear. The symptom triad to know: fever, significant muscle aches, and progressive shortness of breath. If those three develop within 2 months of any potential rodent exposure, go to an emergency room and give the physician the specific exposure history. Do not wait. If you have access to rural properties, older structures, unoccupied spaces, or any occupational environment with rodent exposure risk, assess now. If cleaning is needed, follow the protocol exactly. Ventilate, mask, wet surfaces before disturbing them. Never dry sweep. Double bag waste every time. And if your immune health baseline needs work, sleep, vitamin D, inflammation, start those conversations with your doctor now, not later. Here is what I want from you in the comments. And I am asking genuinely because it shapes what I cover next. Do you have an enclosed space in your life? A cabin, a storage unit, a basement, a shed that has not been assessed for rodent activity? Has anything in this video changed whether you are going to do something about that? And when you first heard hantavirus in the news this week, what was your gut reaction in the first 2 seconds? Not what you know now. What did you feel before you knew anything more? Those two answers tell me everything about where this community's health literacy is and where it needs to go next. If this gave you real, usable information instead of anxiety or dismissal, share it with someone who has been forwarding you the alarming headlines. What they need right now is not more fear, it is context. Subscribe if you have not already, because next week we are going directly into how the aging immune system responds to serious viral threats and what adults over 60 can do specifically and practically to optimize that response in light of everything we unpack today. That video will be directly applicable to your life. I am Dr. Ava Wilson. Be informed, stay rational, and please take your health seriously. Because no one else is going to do that for you. I will see you in the knee.